what we had really in mind in delivering were really patient centered approaches. And I think it's, because there is a whole bunch of different opportunities to really, treat patients, and the current standard of care is chemotherapy followed by Avelumab maintenance. And the question is really, where are the gaps? I mean, how do we interpret the current data, and does it really fill the gaps? And, so I think, there were a couple of points I think that we raised, and one of which has been that the utilization of first-line therapy is not so great overall. So it is surprising when you look into the data, how many patients are not being offered first-line chemotherapy for metastatic UC. So I think that's the first thing. And, what are the barriers really to access to therapies? And so there are many factors that have to be taken into account, actually. And then second of all, I think, that chemo Avelumab maintenance is standard of care. But one of the questions is really, in our clinical studies, we do select for UC histologies. So they have to be predominant UC. So whenever it comes to mixed histologies or pure variants, I think that's where it becomes blurry. It's not depicted in our phase 3 studies. Most of the times it's not part of the phase 2 studies. So, and we do see those patients in the clinic. So is it working as well, in these subgroups of patients? And I think, with the enlarging body of evidence coming from the real world, I think it becomes more certain that even in these subgroups, Avelumab performs very similar when it comes to the efficacy analysis. Of course, that data is limited because it's not a large body of evidence. It's not a huge phase 3 study, of course, and these are rare histologies. But from what we have seen, they behave very similar to the primary, Javelin bladder study.